the only show focused on stars' improvement strategies and the leaders who implement them. This is the Rising Stars with Rex Wallace Show, brought to you by Hyperlift.
Welcome back to yet another special episode of Rising Stars with Rex Wallace. I am clearly not Rex Wallace. My name is Luis Cerda, and I'm a star ratings consultant here at Rex Wallace Consulting. Now, earlier this year, if you remember, we talked about the Medicare Spanish-speaking population in the United States, their barriers to access to care, and how that can impact the star ratings of the health plans with such populations. But once we were done with that conversation, we thought to ourselves, but what about the other minority groups in the United States? What is their situation like? Do they also face similar challenges? And how are we addressing those barriers? Now, that being said, today we want to talk to you about the Medicare Asian American population here in the United States, their barriers to access to care, and how this can impact the star ratings of the health plans with such populations. And today, I have the honor of being joined by three experts in this topic. We have Encarnacion, he is Senior Manager from Blue Shield of California, Lisa Desai, Director of Member Experience at Scan Health Plan, and Allen Suh, Director of Service Segmentation Strategy at Scan Health Plans. Please, guys, introduce yourself to the audience. Tell us about yourself, your position and your company, and anything else that you feel is relevant at this point. Eden, we can start with you.
Yes. So my name is Encarnacion. I'm the Senior Manager for HEDIS for the Medicare Star programs here at Blue Shield, California. I migrated here in the U.S. 16 years ago. So my first job really actually has been in the healthcare space. Prior to joining the health plan, I worked a lot with providers, working directly with their PCP offices and their staff, and really focusing on quality improvement strategies and initiatives to increase our HEDIS rates and overall STARS rating.
Thank you so much. Thank you. Lisa?
Good morning. My name is Lisa Desai. I am the Director of Member Experience at Scan Health Plan. I've been with Scan for about 9 years now, and prior to this, I was working directly with our members through our care coordination department, assisting members in various capacities, but really trying to understand the needs of our different populations and how to best serve them. Prior to that, I was working in the community, designing and developing programs for different types of disadvantaged populations. So it really is of interest to me to understand how people think, how people experience the overall healthcare system, and what we can do to make that process easier and comfortable, and really just to make sure that we're meeting the needs of the individual, especially during these, while they're experiencing healthcare and these different times where it can be a very difficult situation personally. How can we really customize our services to make sure that we're meeting the needs of the individuals?
Thank you so much. And last but not least, Allen, please.
Good morning. My name is Allen Suh, and I'm part of the service innovation team here at Scan Health Plan. We have just over 280,000 members in 4 different states: California, Arizona, Nevada, and Texas. So I'm very excited to join this conversation about our diverse membership and how we continue to focus on improving their service experience and care experience across the whole journey that members experience. I'm a native of San Jose. I'm Korean ethnically. My parents first immigrated with my grandparents to Memphis, Tennessee, so I feel like I have some Southern roots, but born and raised in California, and I'm also a caregiver. My father unfortunately passed away from pancreatic cancer at the beginning of the pandemic after 6 months, and then now my brother and myself are the main, caregiver to my mom, who's just aged into Medicare. She's thankfully healthy, but health issues do come up here and there, and we help navigate that for her. So excited to be here and join this great conversation.
Thank you so much to all of you for joining today. And yes, as the audience can see, I'm the only one not part of this group, ethnically speaking, because I am from Latin America, I am from Puerto Rico. However, what you guys don't know is that I lived in Japan for 2 years. I speak Japanese, and I understand the Japanese culture very well. Maybe not all of the other Asian cultures, but that one definitely. So I feel part of the group. And that's one of the reasons why I also wanted to extend the conversation from the Hispanic speaking population to the Asian American population, and understand what are the situations, what are the needs, what are the barriers to access that we have here. Because again, this is a culture that I also identify with as well, and I really wanted to make sure that we can have a chance to talk about them. That being said, when we say Asia, we usually think about the big names, like China, Japan, Korea. But we have to understand that Asia is about 48 countries. Some of like countries like India, Pakistan, Bangladesh are there. So I also wanted to understand, and let me start there. And I'm gonna start with you, Lisa. Here, um, what is the impact of this specific sub Asian population, for example, people from India, people from Pakistan, from Bangladesh, that are not the Pacific Islanders, at your health plan? Do you have a lot of people from these descendancies in your population, and how do you address them?
You know, we're right now we're really exploring how we can better serve the different populations. I don't know offhand, Luis, how many members we have with that particular background, but I think from our perspective, and I'm first generation, but my parents actually immigrated here from India. So I've and so similar to Alan, what Alan said, I'm sort of experiencing healthcare. They're both sets of parents are both my parents and my husband's parents are all Medicare age now, and so experiencing healthcare through their perspective and their lens, and trying to understand how to help them navigate the different systems that are available to them. And so what our population is, I can't speak to specifically, but I think the way that we look at it at SCAN is how can we understand the different needs of the different populations, and then how do we customize our services in order to meet those needs for those individuals.
Appreciate that. Alan, you are Director of Customer Segmentation Service. So just wondering, do you have any information on the specifics of the population that you serve in terms of whether they're Asian or other ethnicities?
Sure. So at Scan, I think an important part though is the industry is working to better capture this data. So I will say, Scan, we have 10% Asian, about 20% Hispanic, Latinx, a little under 50% white, and then we have this huge bucket of other. But that is of the data that we've captured. And so I think in line with what CMS is doing in terms of asking health plans and payers to better capture this data upon enrollment and through the whole life cycle, similar to when you go to a PCP office and they ask you, what's your preferred language? Is there, I go to a health system, they even ask me about my religion. Ultimately, I think to take into consideration what religious beliefs have may impact the care preferences I have. So similarly, I would just say, at SCAN, we have data captured, but it's not a full picture of our membership, and it's an ongoing priority for the organization. And so, for example, even in our health risk assessment for our duals population, we do ask about sexual orientation and gender identification, which is, I think, a newer concept for Medicare Advantage plans because some generations within the population may not be as comfortable, disclosing their sexual orientation or gender identification, but it is a growing population and it is a need. So definitely within the ethnic population, we are working to better capture that data. And then once we better capture that, I think to Lisa's point, that helps us better address the access to care needs that may differ based on health attitudes, beliefs, behaviors, and different care experiences they've experienced through their life.
Okay, I appreciate that. And Ina, I would like to ask you a similar question. At Blue Shield of California, how are you guys working on trying to identify, the ethnic backgrounds of your population and how to address what their needs are?
It's really similar to what just Alan said. It's really making sure we have the accurate data. So we have been doing our best to have, various methods on how we can collect them accurately. So working with members, working with providers, empowering our providers to help us collect that data as well, because that's the only way that we're able to address what the needs are, identify who the population is, and tailor what we can offer them. So really at Blue Shield, I mean, everyone's weakness, I guess, is data at this point, and it's really making sure that we're doing everything that we can capture that as accurate as we can.
Okay, thank you. I understand that the three of you are based on the West Coast of the United States. couple of things that I was reading about, so I was trying to get ready for this conversation, is that about 24 million people identify as Asian in the United States, according to the Census Bureau in 2021. And most of those people who identify as Asians are actually in the West Coast. So 45% of those 24 million live in the West Coast, and 30% of those actually live in California. So I think that even if you are not, even if you don't get that information on paper, just like going out, you see there's a lot of people who at least look Asian, from Asian descendancy, and I think that it is very important to make sure that you can appeal to the needs of those people. Now, however, one thing that I am thinking of is, for example, when we were talking about the Spanish-speaking population, there's about 35 countries in Latin America, but what we all have in common is that we all speak Spanish. So that was always a constant variable, saying all these people speak Spanish. We have to make sure that they can either speak English, or we have somebody who can speak Spanish. Now, my question for you is language a barrier for you? Because there's, like I said, 48 countries in Asia. A lot of those countries are represented in the Asian population that you have here in the West Coast. And there's many different languages. So are you having any issues with language? Is that becoming a barrier for you? Who want to jump into that one?
I think we've seen that language is a barrier. Sometimes you don't know what the other barriers are until you conquer the language barrier, right? And so, so having people available that are able to speak the different languages and understand healthcare from the perspective of that member is really critical. I think I was talking to somebody else, and they said it begins with language, and I think that is the first barrier. And then from there, you get into how people interpret healthcare, how they interpret health in general. What are their sort of ideas and beliefs around the way that they manage their health, and then the way that that maybe if they are immigrants, what was their experience with healthcare in their native country. And so just understanding those things, but it really does begin with language. And we are actively recruiting folks within our customer service with asking for different languages to be represented. It's not always an easy thing to find. So that is part of the challenge, but I think the language is really where it begins, Luis.
Okay. Allen or Eden, is there anything you want to add to that?
And definitely, just to add on to what Lisa was saying, we ask the member for their written and preferred language. However, the scan system has to support that. So last year, we made the decision on our inbound member services line that we would prompt the member for their preferred language in their language. Because if you think about it, most of us, at least the four of us, speak English. And so to think about the experience for a member who doesn't speak English, and if the prompt asks you, if you prefer Chinese, press 3 in English, that's of no benefit for the member who truly doesn't speak English or understand English. And then unfortunately, and we're still working to solve this, is there's this challenge between scaling and hypersegmentation, right? So for our telesales team, which is inbound prospects, we offer, let's say, 10 different prompts, Japanese, Korean, Chinese, Vietnamese, Filipino. But ultimately, after the prospect selects that, it goes to an English speaker, and we do have to use a translator. But it helps us at least know that this prospect prefers, let's say, Vietnamese, and the person who's answering the phone on our end, they can have the translator ready and say, this person needs to speak Vietnamese, and all of that is done in the back end. So for the prospect, it is a more seamless experience. And then one thing, Luis, I would add is even race and ethnicity within the Asian, let's say, continent is not monolingual or singular. So there are ethnically Chinese individuals who grew up in Vietnam.
Mm-hmm.
There are others like you, Luis, who spent a lot of time in, let's say, Japan or Korea, and they identify more with the culture, maybe more with the language. And so in our enrollment form, because of CMS, we do allow members to check multiple boxes in their ethnic identification. But really, if someone says they identify as Vietnamese and Chinese, then we can't really service both on our end. So there's like a decision point on so do we send out the materials in Chinese or Vietnamese? Or do we have to ask another question to say, for any materials we send out for our secure portal, do you prefer the language to be in Vietnamese or Chinese? So it's more, how do we better capture that member's preference, knowing that it may differ?
Yeah. Because one thing that I noticed, most of the places you call, let's talk about health plans, you call customer service and they say, for English, press 1, para español, presione 2. But something I had never heard, at least not here in Florida where I live, is 日本語だったら3番押してください, or something in Chinese saying like press 3 for Chinese or whatever language. So is that something that is happening at your health plan, or is that something that you think should happen at some point? Is there something, like not, like you said, not telling people that the language or the resources are available in a language like using English, but like actually using their language? Is that something that is in your plan right now for the future?
So at SCAN, we do have it on our member services side. So we do support Spanish, Chinese, Vietnamese, and Korean. And so on the Chinese side, we also have Cantonese and Mandarin, because for spoken, there is that split between Cantonese and Mandarin. And then on the written side for Chinese, most of our materials are in simplified Chinese, but we have also heard feedback for the older population that prefer traditional Chinese. So that's an ongoing discussion internally. So our website is translated into simplified Chinese. However, with some of our medical group partners that work closely with that Chinese membership, they've said they prefer to use traditional Chinese, just knowing that most older Chinese prefer that. So on the spoken side, our member services team has that supported. On the clinical side of the house, and Lisa may have more insight, so like our duals members, we do have some bilingual speakers, but it varies across the care journey.
Mm-hmm. Okay.
And they typically have to go through, the English speaking person to get to the language line. So if they're using a translator, a translation service, I think we all have translation services, which meets a need. But I think a lot of members have expressed to us, of varying cultures, that having someone who speaks their own language, someone who's working at the health plan, whoever it is that they're engaging with, whether it's customer service or case management or whoever it is, they want that person that they're engaging with to be the one who speaks their preferred language. And so that makes the translation services, not always the best answer.
Okay.
Yeah. I'm actually going to add to that. In my previous role before I joined Blue Shield, I was with a different health plan that really catered to the Asian community. I would say about 90 to 95% of our members were actually Asian. So when I started there, it was really, you have to figure out a different way on how you can effectively communicate. And language is one of our biggest barriers. Before, I would just provide scripts or create materials that are just English, Spanish. And now we have to translate it into 8 different languages. And even with that language, there can also still be barriers, because I remember in our customer service, we do have Korean speaking member services, but an older Korean member services versus a younger Korean member services, the language is still different. So we would always get comments like, oh, we still didn't understand because they were speaking more traditional Korean versus, I guess, I don't know, Alan, if there's a real difference with it, but we got members that were saying they couldn't still understand it because the member services that's a bit younger doesn't speak how, an older Korean would understand Korean, I guess. So even with that, providing them with a specific language line for Vietnamese, Chinese, Korean, it can, it helped us cater a lot, to our members, because we're able to service them with, the language that we're able to communicate them with. But even with that, there's still layers within that. Even the member materials, there's some that would say, oh yeah, we speak Korean, we can read Korean, but when you give them a Korean, a written material, they would just give it to, somebody that can help translate it still for them. So it's a lot of discovery with that experience, because we thought that, at least on my part during our quality interventions, we thought we were doing the best that we can, but there's still layers that we had to feel like, oh, okay, we still have to improve this because we're still not quite effectively communicating or really making the members understand what we're really, wanting to relate to them. So
And I think sometimes we forget how complex and complicated healthcare is, right? So, just the other day I was listening to a call where a member, Chinese, calling in for her sister was asking about a IV infusion drug that was denied, and they're trying to make sure that medication, but like medications, the member was spelling the medication name, right? And so even though we offer in language services, it's not easy to get it's not easy for the member to communicate what they actually need because they're still navigating the dominant English culture language. And so like a cancer medication name that's probably like 10 letters long, spelling that out and then trying to understand what can be IV infusion, like what can be done in the hospital, what can be done at the provider's office, how that impacts their copay or the drug authorization process. Like there is a health literacy component, and then now we have to say it in language for that member, and how do we make it easy for them to understand, and then also take action on it. And so I think I would agree, like language is the start, but there's still, I still struggle. Sometimes I'm like, is it more a socioeconomic status issue, a health literacy issue? And how do we, as the health plan, help the member better navigate? And a lot of the work that Lisa is doing on the network quality side is really driving that forward because the health plan, we touch part of the care journey, but we also rely on our care partners to kind of like do the last mile stretch almost to like make sure the member's getting the clinical care they need.
And I'm very happy that you brought that up, Alan, because to be honest, that was my next question. Now, a couple of times I've been to California and I noticed that things are relatively more expensive in California than they are here in Florida. And we know that in the United States, healthcare, it's very expensive. Now, my question is for the three of you guys, have you seen that poverty is a barrier, for your members? Do you have members that are poor or poor enough that they cannot afford the services that they need? If so, I know that most of the health plans, especially health plans who are performing at 4 stars or more, they have more money, they can provide better services. But still, there's people who might be struggling financially. So I wanted to ask you about that. What are you seeing about poverty and socioeconomic status specifically on the Asian population that you serve, and how are you working with that? What are you doing to help your members with that? Eden, let's start with you on that one.
sure, yeah, I can share one experience. Again, in my previous role, I never heard anything like this before. So, with quality and HEDIS, we're always outreaching to members, calling them, help them schedule appointments. What can we do to help you get to, let's say, your mammogram screening or get your authorization for colonoscopy. So this member, it was actually for a medication adherence measure, and we were trying to call them. We have the phone number, but it wasn't working. So we went to the PCP and said, "Hey, do you have a different phone number for this member? Because we want to make sure to remind him to pick up his medication." So the office staff told us that, oh, in certain weeks of the month, his phone line is actually not working because he cannot pay his phone bill. So the office staff gave us the window, like with this 2 weeks you can't reach him, and then once social security comes in after a few days, the phone line is activated again, and then you can call him. So I've never heard such a thing. Usually it's a bad phone number, but never in that kind of circumstance. So now that we knew that the member had that struggle, we can't financially assist them, but we knew the pocket of a time of the month that we're able to outreach to them, and so also coordinate with the PCP if there's any other way we can, reminders for the medication to make sure that he's able to pick it up. And then also just touching base with them at a certain time of the month as well to just check up on them, because you never know, it could be worse than just not being able to pay the phone bill. It could also be food insecurity, it could be housing issue. But just making sure that we're able to touch base with him and ensure that we're able to support them. We are very actively connected with the community as well. So if there's any, what do you call this? community programs that we're able to connect him with, then we're able to give him that access, so he's not, feeling like, oh no, I'm stuck, I don't know what to do, that I'm not going to pick up my medication, I'm not going to go to my screening. But yeah, for us, at least with the Asian community, it's the community is really a resource. They trust their small communities better than the health plans technically. So we tap into that access because they're already established. They already have the relationship. They already understand, at least the geographic area where they're at, and it's really just educating and informing them that they have access to certain things that they probably just didn't know that they were able to get. So yeah.
Lisa, I
And I
will
think
assume that as director of member services, you're also dealing with a lot of situations like this.
we do, and it can come in through the inbound calls, or like Eden said, a lot of our outbound calls where we're finding out that the members have greater needs than what it is that we're specifically calling for, that their needs are greater than that. And a lot of it is identified through our health risk assessment as well. So we try to be proactive in connecting members to resources. Our entire member services team has community resource, like an application that they use that can identify different community resources for members if they have food insecurities and things like that. We also do have some different benefits under different plans. So we try to connect our members to the different benefits that are available to them as well. But yeah, we've heard it from a lot of our members that, a lot of times it is that decision between, food or medicine. And that's a terrible decision for people to have to make. So we want to just do whatever we can to make sure that the member has access to the things that they need, and where can we insert ourselves and support them. The vast majority of people that are Medicare age are living, either at a poverty level or just above, just slightly above. And so that really does make for very difficult decisions to be made. And especially living here in California, where just the cost of living is just so much higher. We have to have a constant awareness of that, and making sure, like Eden said, that we have a pulse on it, and that we can identify what resources and services we can provide to ease that burden for those members.
Okay. There's so many things that we could be asking and we can be talking about. So I'm gonna be just like touching a little bit on these different things. And actually, Allen, this next question is for you specifically. So I'm thinking, and please bear with me here. My first language is Spanish. So when I'm choosing a doctor, I usually like to go for a doctor who speaks Spanish because I'm going to feel more comfortable talking to him or to her. And if they're, and if they're from Puerto Rico, even better, because they might understand me. Now, my question is, probably you can answer that, Allen, because you work with the segmentation. Are you seeing a lot of issues or situations, not issues, but situations where people is like, I really would like that there are more Asian-looking doctors, or I really would like that there are more Chinese doctors, people who can speak my language, but because I will feel more comfortable instead of going like to see a white doctor, And it might sound like, wait, what is he talking about? Well, but remember, we're talking also about stars. We want to make sure people has access to care, and I think having access to care is making sure that people can see the person that they believe that they need to see. And that they can feel comfortable talking to that doctor. So maybe they don't want to go see a white guy. Maybe they want to go see somebody who looks like that and they feel more comfortable. So again, my question is, are you see something like this, or this is not really, an issue and something that we're mentioning?
I would agree. I think it is a need and preference for many members, especially in the Asian membership, especially if they want to see a doctor that speaks their language, because language is the starting point, and then even educating the member about taking their drugs or getting a routine screening, that's another barrier that the provider has to cross. And so we are internally working closely with our medical groups. I think, as you mentioned, Luis, one of the benefits for a member, let's say living in LA or Orange County in Southern California, even Northern California, there are providers that do speak the language. And so let's say for Korean and Chinese, we have 2 or 3 key medical groups that we work with, and they have panels available where the PCPs do speak the language. Then the question also becomes, in the more rural areas, how do we meet that need? And then beyond PCPs, what happens when they want to see a dermatologist that does speak Japanese or speaks Chinese? And how do we improve access throughout the care continuum. And so
Hmm.
that's like lab, imaging, even internally, we did a dental experience validation where that exact use case, the member wants to find a Korean speaking dentist. We identified data issues on our partner where when you search for a Korean speaking dentist, we call those dentist office and sometimes the dentist isn't available or no longer practicing there. And that is a common, well, I won't say common because hopefully the industry, I know the industry's been working to improve provider data management, but that's like a very clear gap where we can say, oh, the member can find and we have in-network Korean speaking dentists, but the reality is it's harder for the member to actually find that Korean speaking provider or Chinese or Japanese speaking provider. And I would agree. I think it is a need similar to the Hispanic population where they do
Hmm.
want to see a provider that is culturally competent in their needs.
And I believe,
It's a good. I'm sorry,
go ahead,
Luis. It's a
go ahead,
good
go ahead.
point, Alan, because it's language is part of it, but culture is part of it too. You know, understanding culture, understanding traditions, understanding just how people interpret healthcare, what's their idea and understanding of healthcare for all the different, different cultures and different segments of population that we serve. It's important to understand how people understand health, their own health, and manage their own health. And a lot of that is cultural. So having that awareness in your provider, if you choose to use herbal medications, if you choose to go more homeopathic remedies, things like that, you'll see a greater prevalence in different cultures. And so it's important that your provider understands that and that they can help to guide you, and they're part of your health management rather than just somebody that you go and see. It's really a partnership.
It's like you guys are reading my mind today because like you just keep mentioning things that I wanted to touch upon. So again, I keep comparing, the Asian culture with the Hispanic culture because believe me, there's a lot of similarities. So at least for my experience in Japan and being Hispanic, people, especially older people, they believe a lot in home remedies. Like you say, like herbal teas or like things that are actually like the more natural that you can go, the better. But I also know that, in Asia, again, 48 countries, I know there's a lot of religions, and I don't know much about this. So I want to ask, what do you guys think what role does religion plays into getting people to go see a doctor? Whether it's religion, whether it's culture, do you see some sort of hesitance from people to go to the doctor? No, because of my religion. No, because I prefer to do, go with the herbal teas. I don't want to pop pills. I don't want to have a surgery. There are many things. Again, I'm not an expert, just a little bit what I know, but I want to ask the three of you if you see culture, religion being a barrier and a factor of people actually getting the care that they need.
I can speak on that. Working, in my previous role, it was the first health plan that really, offered Eastern medicine along with Western medicine. So it was, again, a really eye-opening experience how much, you know, people really wanted access to the Eastern, herbal medicine and herbal supplements. On the quality side, it was really challenging for us because if they're diabetic, we want them to take their statin or be adherent with their diabetic medications. But we hear them, oh, we're just taking this herbal supplement. We don't really need, the Western medication to control our diabetes or a blood pressure.
Mm-hmm.
My dad does. I mean, it's classic example. I mean, he's not here. He's in the Philippines, but he takes turmeric tea every day. He said it's better than taking his metformin. I'm like, okay. To me, as long as it helps him, that's great. But when you look at it on, our quality improvement side, it's not that they're not being healthy or trying to be healthy. It just doesn't quite translate to the data that we're seeing. So now we're pushing other alternatives or getting their medication even though they don't want to take it or they're a little hesitant to take it. So it's a lot of really just you just have to have an open mind and really listen to what they're saying. I think one thing is having the provider that can understand the practices or the other alternative medications that they're doing, but also as a health plan, I think it's an important thing to understand because again, on the quality side, it's always why is the gap not closed, right? It's a yes or no usually. Well, the
Hmm.
member doesn't want to see the doctor, the member doesn't want to take the medication, but you have to really dig in why. So if it's more of a cultural, barrier or just their belief, it's really just understanding that and finding a way to uh, you know, uh, provide them with the education on, why do we think this might be a good alternative, but not really change, what they are already doing. Because to me, honestly, as long as they're, doing their best to stay healthy, that's half the battle. They're at least not being in the hospital, for example, or they're not having an admission. So, or staying away from the ER. But yeah, to me, I've seen that a lot. And even in the medical records for some of the members that we were targeting, it says there patient taking herbal supplements, but not really the medication that we are trying to. I don't want to say influence, but just because of our star measures, that's the specific medication they need to take. So yeah, so it's really, again, understanding, having an open mind, listening to the members, not see it as a one size fits all. Really, a lot of from my experience working in quality, it's always a one size fits all approach. And then now seeing a different, segment of this population and understanding what other alternatives they have, it's again being just, having an open mind to what they are currently doing to help improve their health outcomes.
And that, I think there's definitely aspect of trust and communication. So in
Yes.
Asian languages, there's more indirect communication. So is the member even disclosing that they're doing acupuncture or herbal medicine? And is the member actually being guided in that? And so like the member may pick up the script for the statin, and then on the back end in the data, they've never filled it this past year. And it's like, why? And part of that is trust and communication. And can the member actually share why they're not filling the prescription?
Hmm. Hmm. Completely. Yeah, I agree. Lisa, any comments on that one?
I think I agree. It's very individual, and I think in different countries you have to look at also what people's exposure has been. Like if they're not native to the U.S. or if they're immigrants to the U.S., what was their exposure to healthcare in their country? Is it? I think the healthcare system in the United States is one of its own. It's unique in that sense, and so everybody experiences healthcare a little bit differently, and the priority that they place on it. Do they really feel like they need to see a doctor with a certain frequency, or do they just manage their health themselves? And that's, in a lot of countries where maybe you don't have as much access to healthcare, maybe that's what people believe, that they just are supposed to manage it themselves. They have different, herbal medications or different, things that they, different ways of managing through diet and exercise and things like that. And people feel like that's how they manage their health. And so it's not always about healthcare, and so understanding those needs and being able to be responsive to it. But again, I think like Alan said, is just like that trust, making sure that you have that trust built in and that the member feels comfortable enough to disclose these things and discuss that with you and to be able to say, I'm not going to take that medication. I don't really believe in medication. And so I'm not going to take it. And so, okay,
Hmm.
let's figure out
Hmm.
something else. There's a different way. Like Eden said, there's a different way to manage people's health. It's not just the way that we manage health in the United States. It's just different. Everybody has a different perspective on this, and understanding that is really critical.
It's been interesting throughout the conversation. We have kept coming back to the same point: language communication, language communication. It's understandable because, again, there's so many Asian countries, there's so many languages. Like you mentioned, Alan, even for example, within China, there's so many dialects. How do we make sure that we communicate with all of these people? And yes, we know the primary language here in the United States is English. A lot of these people will eventually find a way to communicate in English. The ones who are coming here, establishing, or having kids, grandkids, they speak English. Is going to be it's going to get better with time. But that brings me, I was also reading that according to the U.S. Census Bureau, we are expecting the Asian population to reach 46 million people by 2060. So I think we eventually are going to have enough people to communicate with everybody who's here. We're going to have enough people, to have a good enough representation, and we're going to have the resources that we have. Now, the question is again, in the meantime, how do we address all of that? I know that we are running out of time, but I wanted to give you guys a couple of minutes to summarize. Let us know what's the most important thing for you when you think about the Asian population specifically that you serve? What are you doing? What is your company doing? What do you have in mind? What is your dream? What does this look like for you, utopically in the future? So again, I will start with you, Eden, on that question.
Yeah, so for us, at least, again, it's really making sure that we're gathering accurate data because that's really the baseline of where we can start and what we can do. And then once you understand that data, it's really also, again, understanding the different cultures and beliefs. Again, most of my experience is really on the quality improvement side. So it's really versus just forcing Western medicine, for example, versus, okay, let's see if there's any alternative ways if they are able to manage, certain chronic conditions, then, you don't have to force anything to the members because that's where trust and relationship comes in when they see that you're able to listen and understand them. Then you're going to be able to effectively build that with them, and maybe next year they'll consider something different, right, or something new. And I think also what we, at least at Blue Shield, what we're doing is really tapping on our community. There's a lot of different pockets, here in Los Angeles that I think not a lot of people are aware of. So just partnering with them, what we can do with them, because they are out there. There are boots on the ground. So whatever we can support them and help them with, reaching to more of our members, I think that is the best solution, right? Because honestly, with Blue Shield, we haven't really tapped that as much as we wanted to. So it's really improving that, being more out there, be a resource to our Asian community, and have that relationship with them. And then again, with that, we're able to build and test different programs, offer them different, more benefits that can help, tailor what their needs specifically are.
Thank you. Lisa and Allen, I know that you work both at SCAN, so just want to ask you directly, Lisa, what exactly are you, in your position, in your department, working on to make sure that you address the needs of the Asian population in your plan?
So yeah, thank you, Luis. What we're doing is we're looking at the overall experience of the member from sort of end to end. What does that journey look like? What are their pain points? What are the things that where do we need to make changes in order to be more responsive to what the members' needs are, so that those different experiences that they have that may not be positive, that we can avoid those and make sure that that journey is seamless and that we're responding in a way that fits the needs of that member. So that's the way that we look at it, and it is a very customized sort of. Right now, we're sort of in that discovery, trying to understand what that journey looks like, and then we would like to be able to then create a customized journey and then scale that so that we can serve more people in through that lens, and just making sure that we understand. So my vision really for the organization is if we can do this and do this broadly, so that everyone throughout the organization understands that the experience is different for different populations, and that we are adaptive, and that we understand that collectively, and that we will make sure that no matter who you talk to, that person understands that yes, that your journey is a little bit different, and we're going to make sure that we're able to provide the services that you need in a way that works for you as a person.
Thank you. And Allen.
So one thing SCAN Health Plan and Care Oregon did this year together in partnership was retire medical debt. And I bring that up because it'd be really interesting to see the ethnicity of those individuals that we retired medical debt. So are certain segments of our membership or general US population experiencing healthcare at a disadvantage? And so really the SCAN team is looking at health literacy. The part that I'm excited about is how do we continue to use technology? So we may not need a bilingual Korean speaker if that member prefers to text, email, live chat, secure message, and how do we support that? So we could use a bot. Technology has improved a lot, and that's a starting point, and we still want to have a human touch. But how do we really use technology? Because even though that population is growing, we can't meet every single member's needs just, because GDP and healthcare, right? We know the story. We're already spending so much on healthcare. Mm-hmm. And then if we need to have everyone, every language supported, that's a trade-off decision. How do we best meet that need? So I'm excited about how Scan will continue to use technology to meet those unique needs of our membership.
Thank you so much. And pretty quick, if the audience is interested in reaching out to you, getting to understand better the things that you're doing, or they just want to get in touch with you, where can they reach you at? Allen, let's start with you.
They can reach out to me on LinkedIn or asuh@scanhealthplan.com.
Thank you. Lisa?
Yeah, same. LinkedIn is probably the best, so I would love to hear from anyone.
Wonderful. Eden?
LinkedIn as well. I would give my email address, but my last name is too long, so they can find me on LinkedIn. That'd be
Okay, so
great.
everybody's on LinkedIn. So to the audience, if you want to talk to Eden, Lisa, or Allen, please feel free to reach out to them. Thank you so much to the three of you. Thank you for this conversation. I think it has been great. I really appreciate that. Like the Japanese said, Kyo mo makoto ni arigatou gozaimasu. Minasan kyo tsukete. Sayonara. Thank you so much for your time. Bye-bye.
Thanks for having us.